Welcome to Inside View. My name is Cory Burnell, and I will be your host for this episode. And I'm thanking you for joining us. And I also want to thank our guest, Dr. David Arnold, who's a dentist here in our area. David, thank you for joining us.
Pleasure. Our pleasure.
Well, David, for benefit of our guests, tell them a little bit about where your practice is located and perhaps how long you've been in, practicing dentistry in our area.
Sure. My practice is in Arnold. I can't beat the name.
They named the city after you, right?
It works. Yeah, I had to change my name, but no. I've been a dentist for 43 years. I graduated from USC Dental School in 1975, and I opened a practice in Walnut Creek. And so I had the practice in Walnut Creek until I made the decision to buy the practice in Arnold, who a friend of mine had that practice, and he had opened a practice in Sonora. So this one kind of came available. It was more like a stepchild of his, and so I kept in touch with him because this was the area that I brought my kids to go camping, and it's just, it was a dream come true, really, to have an opportunity to move up here. And I commuted back and forth between Walnut Creek and up here for a year and just making that transition. And then we physically moved up here in 1991 and been here ever since.
Wow.
I'm a very lucky guy.
You really are. I mean, shoot, that's what, 27 years now?
Yeah,
I'm doing the math, right?
And I'm lucky that I've got a job that I can live in a small town, and it gives me a way to make a living and being able to live here. This is the best of all worlds.
I'll tell you what, man, you're speaking my language. I'm an investment advisor. I don't know if you know that, and I have an office in Valley Springs. My wife was born and raised up here, and one of the most tremendous benefits I have is that my commute is 4 minutes, and I live in the foothills, and where other people have to weekend or plan their trips up here to do all the things that we love to do in Calaveras County, we get to do it at a moment's notice.
Yep.
Particularly if you're even further up the highway in Arnold.
Well, we found, I think my daughter might have still been in diapers, and she's 42 years old now, but we found big trees, and I grew up in the Seattle area, and I was one of 6 kids, and that's what we did. We camped, and so it was just a natural progression for me to do that with my children, and so we found big trees and then found Lake Alpine, and I thought I'd died and gone to heaven.
Oh, yeah.
And I just had a birthday, and that's where I spent it, was up at Lake Alpine. I just love it there.
It's a special spot. I mean,
really
camping there, and then you have the restaurant right across the street, and you can kayak or boat on it.
We have done all of the above, and had bears wander through our campsite, and all of it, and it's just, we live in paradise, really.
So when you were looking on a map for where you might want to camp, it didn't have anything to do with when you saw a city of Arnold, and you didn't put your finger there.
No. The thing, the whole Arnold thing is, it's just more of a coincidence than anything. It just happened to. We camped up at Lake Tahoe. We camped at Yosemite, and then we found this corridor.
Sure.
And then in the late 70s, early 80s, my brother bought a vacation home in Lakemont up in Arnold, and which he still has. And then when my mom and dad retired, they built a home up in Lakemont. And so there was just, the thing is, when you're taking your kids to go camping, and they know their uncle's house is right there in Lakemont, and there's a little lake, and there's hot showers and warm beds, and Dad's going, no, we're going camping.
They don't feel like camping right now.
Dad, have you lost your mind? But it was just, you'd ask my father, he would have said, yeah, he found the whole town and everything. But it was really just turned out this way. I hear it all the time, believe me.
Sure. Well, that's a neat thing for you and your family to get to share with the town you live in, and the fact that you've been there as long as you have. I'm sure you feel very knitted to the community.
Oh yeah. And that's the beauty of Arnold, of Calaveras County. Is that it is a community, you know, that it being, you know, a real integral part of it. And when we first moved up here, I got involved with the disabled ski program at Bear Valley.
Okay.
And so we've been involved in the community all these years, and it's great to be able to be recognized and have people come up and pat you on the back. And I mean, it just doesn't happen. It didn't happen like that in Walnut Creek.
I'm sure it didn't. Originally, I'm from San Diego, and I married a small town girl up in Valley Springs. So, yes, I've experienced that.
My wife grew up in San Diego. That's
where she did. From. Okay. Yeah. So I've experienced that contrast as well.
Oh yeah.
But you know, I mean, we could spend the whole half hour, of course, talking about how great Calaveras County is. That's why we're here. We love it. So let's talk a little bit about your practice and some of the things we were going to talk about in the way of dentistry, so our viewers know here. So we're going to talk about some of the advances and how they compare to the history. I know as a patient, when I go into my dentist's office, things have changed in my lifetime quite a bit.
Oh yeah.
So you know, if you've been a dentist for 43 years, let's talk a little bit about some of the advances you've seen.
Oh my gosh. Oh my gosh. I mean, one of the latest ones, which I really think is, and it's really a simple thing. I mean, you'd think dentistry, the advances would be very technical in aspect, and of course they are. The bonding, the chemistry of bonding, the materials that we use to bond, the materials that crowns are made out of now, and all. I mean, just the advances in general. But one of the things that kind of sticks to me as something new is something that was old, and now it's new again, and it has to do with a material very similar to silver nitrate. And it's called silver diamine fluoride, and it goes along with the whole idea of minimally invasive dentistry.
Now, silver nitrate would be those old dark fillings that we had, right, when we were kids.
Exactly.
Okay.
Exactly.
So this
was kind of a blackening of the decay.
Yeah.
Without having to remove it necessarily, you just killed it, and it was brought up in the 40s and the 50s for rural areas, you know, where kids didn't get to a dentist. They would just put silver nitrate on decayed areas and kill the decay. Well, we have now a population of elderly people. I hate to, because I'm getting
boomers.
there.
Boomers, yeah.
But boomers, yeah. Geriatrics or boomers or whatever. Anyway, we now have a population of aging people who have their teeth.
Oh, interesting.
I mean, 70s and in their 80s and
so
in their 90s.
Even boomers' parents in their 90s.
We've never had this before.
Right, of course. All the time. I remember my grandfather, when he was 90 years old, his teeth were gone.
Right. Yeah. And either they didn't live to 90, or when they got there, they didn't have their teeth.
Right.
And that was the more common thing. But we have now a population of people that have had their crowns for 40 years or 50 years. They've had, you know, and they've got gum recession, they've got root exposures, they've got things that, from a dentist standpoint, is very difficult to manage, because if you're doing a filling on a root on a lower incisor, you're almost cutting the tooth in half because the tooth is so delicate, it's so small. And so if you go in and remove decay, even if you're putting a filling there, that tooth now is very fragile. It's even more so. So now we can put this material on there. It'll turn that area black, but you won't see it because it's down. And now we've got a tool to save that 40-year-old crown rather than having to replace it on a 75 or an 80-year-old, which doesn't make sense to me. I mean, it's just like, here we are doing a procedure that you're looking, you know, for another 30 or 40 years on an 80-year-old.
Right.
It's just,
and
it's invasive and it's expensive.
Right.
Oh, this stuff's cheap.
Yeah.
I mean, and it takes a very minimum amount of time.
Right.
And so, you know, it's kind of, when I first saw this, it was just buried in a journal, and some guy at UC San Francisco was toying with this whole silver nitrate idea and tweaking it into this other material. But I couldn't buy it. It was a great idea. I just couldn't find it anywhere.
Nobody was supplying it.
Nobody was supplying it. And then it hit another journal, and then finally it got as a cover story on a California Dental Association journal. And it became available, and it was interesting because the title of the article, "What Was Old Is New Again," And to me, I mean, it's such a simple thing, but it's an advancement that fits our time, you know, and I think it's important that we can provide a more minimally invasive kind of procedure instead of, you know, having to do something that's much more costly and much more invasive on people that I don't think at this point in their lives they need that.
You know what leaps out to me about your experience with that is something that I've shared with clients and prospective clients in my practice, and people generally know this when they're looking for a doctor or a lawyer, and so our viewers may want to apply what I'm about to present here to dentistry, for example, is that we know to sometimes get a second opinion. When we have a legal problem or a medical problem, oftentimes we know some doctors are better than others. Some lawyers are better than others. In my profession, some investment advisors are better than others. And what leaps out to me about what you just said is that if you hadn't been looking for this solution on your own, if you'd just been going with whatever the status quo was, your clients wouldn't be benefiting from this solution. And so what jumps out to me is that you're the type of person in your practice who's looking to improve your practice for your benefit and your client's benefit.
Yeah,
so
I read a stack of journals every month.
There you go.
And I don't know that everybody does that.
My point exactly.
But you know, another example is that really big in dentistry is airway. Is treatment of the airway and sleep disorders, sleep disordered breathing in children, and some of this stuff I actually lecture on at UCLA. But you know, dentistry has just moved in these different directions. I mean, again, back to the technical things, the bonding and the crown materials and all of this sort of stuff. Sure, that's going to advance. Lasers, you know, we're using lasers in dentistry now.
Yeah.
And so there's this whole technical aspect of it that's going to move forward. That's just the nature of things. But it's the application of dentistry as a solution for a breathing problem. You know, using an appliance to bring the jaw forward while somebody sleeps.
What about diagnosis of that? Do dentists diagnose that, or is it?
There are some home studies now that we have available that we can screen people. I as a dentist cannot diagnose sleep apnea. I mean, it has to be done by a physician, but we can screen for it.
Okay.
And technically, I can treat snoring, but unless sleep apnea is diagnosed. But now there's a myriad of steps between a simple snoring issue to severe sleep apnea, and there's different terms for it. I mean, sleep disordered breathing is kind of the new buzzword, and but you know, I heard of some of these things back in the 80s and kind of stuck my nose, and I designed an appliance, didn't know what I was doing, but it was you know, the dentistry has always been perceived as, you know, fixing teeth. You know, and it's anything but that.
Goes
I mean,
well
I do
that.
a lot of head and neck pain treatments and TMJ problems, jaw problems, and then you get into posture and you get into breathing, and it's just, you know, dentistry has moved forward technically, but it's also moved out in all sorts of different directions.
Okay, an application.
And I think that's kind of my point. You know, is that here's something as simple as just being able to put a little bit of, you know, take just a small little cotton thing and put this solution on a little filling or a little cavity started on a root surface, and yet to me that's a huge advancement.
Absolutely.
Because it's so applicable.
Well, and to be clear on what that solution is, it kills that part of the tooth so the decay stops, the cavity stops.
Yes, it kills the decay.
But the physical portion of the tooth remains, so you still have that support.
Correct. It only kills decay.
And
then
it won't kill living tissue, the living tooth.
No, well, you have to guard the tissue, the soft tissue. You have to guard the gums a little bit. But what's really interesting, and again, we have imaging where you can get down to the molecular levels, where you see the studies with this material, and it kills the decay, very specifically killing the decay without hurting the other tooth structure, but it actually strengthens the other tooth structure. The silver itself penetrates the tubules of the tooth and creates a barrier.
Oh,
and it's actually approved not only as something as a carry suppression or decay, suppression, but also as a desensitizing unit, because it actually strengthens that surface underneath the decay. Yeah, I mean, something really simple, and yet to me it's really exciting. I mean, it's really cool stuff.
It should be. I'm a tremendous fan of that. You know, the world has problems. We as human beings have problems, and I'm a tremendous proponent of that. Technologically, we'll figure out how to solve the problems that we have. Now, on the subject of sleep apnea, our viewers may be wondering whether, they've heard about this. Is that really all that important? So can you talk about some of the problems that a person suffering from sleep apnea may have, and why they ought to look at a solution or talk to their dentist about, well, how do we fix this?
Sure.
They may not even know what's going on in their day that is causing them to have trouble because they're not getting a good night's rest.
Right.
Day after day.
Right. Yeah. Well, sleep architecture is a very complex subject, but breaking it down to the sleep apnea is a cessation of breathing. An apnea occurrence is stop breathing for 10 seconds or more, and the way it is, it's graded has to do with how many of those occurrences happen per hour. But there's also a thing called hypopnea, which is a 50% obstruction of the airways. So you've got complete obstruction and you got partial obstruction. But you take the number of those that occur in an hour, and that becomes what's called a respiratory disturbance index. And that's how you grade it, So like 0 to 5 is normal, 5 to 20 is mild, 20 to 40 is moderate, and then above 40. So you're talking about, for somebody with severe sleep apnea, they've got obstructive disorders occurring 40 times an hour while they sleep.
And they can never get into a deep sleep then.
Well, not only that, I mean, you get all of these disruptions in the sleep architecture. So you start down, stage 1, stage 2, stage 3, stage 4, and then there's REM, and then there's non-REM, and then you come back out. And each one of those cycles takes 90 to 120 minutes. So you get all this fragmented sleep, so you never get through all of that. You might hit little parts of it, but more importantly, when you obstruct your airflow, you're going to decrease oxygen. And so when you decrease oxygen in your system, the body knows that. I mean, you've got receptors all over your body monitoring oxygen all the time. So as soon as there's a lack of oxygen, as soon as that depletion begins, then all of these receptors start sending messages to the heart, the right side of the heart, pulmonary side, which pushes the blood to the lungs. So all of a sudden there's all these messages coming to the heart going, hey buddy, you got to work harder here because we need this oxygen that we're not getting right now. So all of a sudden it starts having to work harder. And so now your heart's having to work harder to compensate for the lack of oxygen. And that's pretty important when, the most common time for this to occur is in the 50 to 60-year-old male, unfortunately. And somebody that's already got hypertension. You've already got a little bit of high blood pressure, and now all of a sudden there's one more thing that's putting pressure on there. And so there's that physical aspect of it, that occurs. Plus there's just the whole sleep architecture fragmentation that occurs, and now you've got somebody that 2:30, 3 o'clock in the afternoon, they can't keep their eyes open.
Right.
Because daytime fatigue is one of the primary symptoms of sleep apnea. But let me push this a little bit further and start talking about it in a 5 or 6-year-old. Because I've had 5 and 6-year-old patients with severe sleep apnea because of tonsils and adenoid obstructions. So now you've got somebody that's a mouth breather, has got all these obstructive tissues in the back of their throat, and these kids, they can't breathe very well. And so now you've got all of that same physical happening with the obstruction and oxygen desaturation, but now you're talking about that sort of effect on a person that's growing, that has a brain that's growing, and cognitive skills and memories and concentration and focus, and on and on and on. And now you're talking about how really serious this can be. And the child now had, you know, this is the kid that is going to be, not going to be, but can be misdiagnosed with your ADHD.
Sure.
Because they're getting all twitchy and everything at school in the afternoon because they can't stay awake. And so the medications that they give for attention deficit is actually a stimulant. I don't know whether you know that.
I didn't know that, but that's something.
Yeah, it's a stimulant, and in a child with true attention deficit disorder, it works just the opposite. It slows them down. But a person that has a sleep disorder, it's going to wake them up, and then it's going to work. So, but it's really interesting in the pediatric literature now. This is one of the other journals that I read. They're talking about that if a child is being diagnosed with attention deficit, they should have a sleep study, regardless of age, because it might be a sleep problem and could be treated in different ways.
That's fascinating. Without this discussion, I would never even remotely think that the case. You think that the kids got too much energy,
right?
And yet they're overcompensating for the fact that they're unrested.
That's exactly right. And there's a lot of research on this. I mean, when I lecture at UCLA, it's with the orthodontic and pediatric residents, and so there is a lot of attention now to the pediatric community and snoring and sleep apnea and sleep disordered breathing and just all of that stuff now is, and dentistry's we're right in the middle of it because we're seeing these kids more frequently than the pediatricians are.
Well, yeah, if they do a cleaning twice a year, you're seeing
them.
Right,
so we should be asking the questions.
Right.
And that's why I want to lecture and why I'm really passionate about this, is because we as dentists are right smack the middle or the beginning of being able to ask the right questions. You know, ask mom, and moms know, they usually know before you do, you know, does your child snore? Snoring is pathologic in a child. A child should not snore.
Interesting. Okay.
Yeah, absolutely not.
So there is a problem if a child is snoring.
Correct.
Okay.
Yeah.
And sometimes that can be tonsils, it seems like.
Yes, yeah, and generally it's usually something like that. I mean, very seldom do you have a kid that is normal weight and good nutrition and they've got they're snoring or they've got an obstructive disorder as far as their sleep is concerned. There are some exceptions to that, but it's very, very uncommon.
Where would someone go for a sleep study if our viewers are thinking, well, gee, I should have a sleep study done?
Got one right here in San Andreas.
At Mark Twain?
Yeah, right out of the hospital here.
Oh, great.
Yeah, we're very fortunate that we have one. It's just up and around the corner. So
so I would imagine it's an overnight stay, is it? And they hook things up to you that monitor?
Yeah, and that again is something that we're really starting to move toward more home studies.
Okay.
Because to me, you know, if you go to a little room in a hospital or
you might not sleep well.
Yeah, you're not sleeping.
Not normally, anyway.
And they're, you know, putting these little pads and wires and stuff on you. And, and it's comprehensive. It's very thorough, but you're not at home. So I don't know how accurate it is.
Well, are there packages or technology you take home with you?
Right, that's where it's moving. It's moving in that direction.
Is it expensive?
I think insurances, again, I'm kind of, they don't let me in that loop very much. You know?
Sure. Well, you're the guy getting paid. No, you're not the guy getting paid, are you, for the sleep study?
No, I'm not at all. No, I'm just, you know, who am I? I'm just a dentist, you know. But it's a, I think if anybody has any kind of medical insurance, I think that there's a lot of coverage. And there's a lot of attention to this now. So where it might have been a little bit more difficult to get some kind of medical coverage, that I don't think that occurs now.
Yeah.
I think that, but I know initially when they first started doing these things, yes, they were pretty expensive. But now it's becoming more common. And these take-home sleep studies, it can be a matter of a couple $100.
No.
I mean,
then
the ones that I'm familiar with anyway.
Yeah, reasonable for anybody to do it who really is interested in doing it.
Right.
We have a few minutes left, and you know, I thought it would be fun in our conversation here to talk a little bit about the advancements in the dental profession over the years, because if we were to walk Well, out of here and just kind of down the hill a little bit, actually I guess it's that way, we would get to the museum on Main Street here in San Andreas, and they have a little exhibit in there with historic dental artifacts, right? And dentistry of the 1800s, call it the 1850s.
Right.
And boy, that stuff looks painful, right?
Yeah.
So,
Yeah.
so I know today things are a lot less painful. What's going on in the way of dental tech that makes things much more comfortable for your customers? If there's anybody watching who says, I haven't been to a dentist in a long time, I should probably go see Dr. Arnold, but the heck if I'm going to do that,
well, you know, first of all, and one thing I tell people who will come in like that is guilt does not exist in my office.
Okay.
I mean, so don't come in and say, oh, gee, I didn't come in. I feel guilty. I haven't been, blah, blah, blah. It doesn't exist. But not in my office anyway. But yeah, I mean, there's just the advances in just the anesthetics that we use and the topical anesthetics that we use. I mean, very, very seldom does anybody ever feel we give an injection. Because it is done so carefully, and we have materials now that are just so much more effective, that pain is really a thing of the past.
Okay.
I mean, there is I don't do sedation in my office, but there are some offices that they do sedation, and of course
now,
the
by
oral
sedation,
surgeon,
is that putting someone under, or is that the laughing gas, the nitrous?
Either or.
Okay.
Yeah, either or. I had a little trouble with the laughing gas being stolen out of my office, so I don't have it there anymore. So my insurance company didn't like that at all. Not the third time. So, but just dentistry, it's just so much more efficient. It's so much more just non-invasive and pain-free. I mean, I can't even compare the patient experience to when I came out of school. I mean, just the whole approach, our knowledge of the, you know, being able to get people numb and keep them numb. I mean, people will come and go, you know, the guy just gave me shot after shot after shot, and I just didn't get numb. And it's like, well, that doesn't occur anymore.
Okay.
It just doesn't happen. We're better trained, and we have better materials.
Okay.
And we're using lasers now, you know, for certain procedures.
Yeah, talk about that for just a minute. We've got about a minute left.
Yeah,
here.
all the way from helping and assisting in having your teeth cleaned. There's some laser things where it used to have gum surgery, where now I'm just taking a little diode laser and just cleaning out the pockets and cleaning out
really?
in and around
What does that
the teeth.
do? Kill the germs or the plaque? Or,
and we can remove the diseased tissue, and we get a nice healing and non-inflammatory response, which is very effective. We're starting to move toward the use of lasers in teeth. I mean, actually being able to prepare teeth. Because we have bonding and things are much more minimal now, we can do that.
Yeah.
So yeah, it's all moving. It moves so quickly.
And what about reparation of enamel? If somebody's had their enamel eroded away due to maybe acidic drinks?
Right. I mean, now you're talking bonding agents. You're talking veneers and things like that. Again, very minimally invasive, and materials that are. I mean, we're using these zirconia porcelain hybrids now, you know, and things that are strong and yet very translucent and beautiful materials. And in situations like that, again, we've got these tools at our disposal that, you know, even 20 years ago we didn't have.
Well, we're just about out of time, but I think the takeaway that we have here is there's certainly no reason to not have a conversation with you or someone's dentist about what problem they have, because there's probably a very good, convenient, and sounds like pain-free even, solution for what the customer client needs these days.
And there's always alternative. There's always options, and I think that my primary responsibility is an educational one. I mean, that's the first thing I need to do, is just inform somebody as to what their condition is, and then talk to them about what their alternatives are and what their options are.
Really a consultative approach.
Right,
Yeah.
right.
Well, again, my name's Cory Burnell. This was Dr. David Arnold from Arnold, dentist up there. And so if you are anywhere near the area and need a new dentist, come see Dr. Arnold. And thank you for joining us on this episode of Inside View. We'll see you next time, I hope. And until then, take care.